This meeting is being recorded.
Hello, Arun. Good evening.
Hey, good evening, ma'am. Good evening. Good morning, Dr. Kev.
Good morning. Long day, the end of the long day for you all, I'm sure.
Hi, Indumati. I think I'm meeting you for the
Hello.
first time.
Yeah. Hello, everyone. Thank you for joining. We'll just wait for a few more minutes for participants to join, and then we'll begin shortly.
Indu, we have some 20 participants right now. We can start, I think, and gradually people will join.
All right, sure.
We're already 2 minutes into the webinar.
Yeah. Welcome, everyone. Thank you for joining us in the webinar today in our latest Climate Smart Healthcare webinar. Today, the topic is on telemedicine in climate smart healthcare, case studies, opportunities, and challenges. And before we get into the webinar, I'd like to give an introduction to our organizations and the work that we are doing. Healthcare Without Harm is an international NGO with a mission to transform healthcare so that it reduces its environmental footprint, becomes a community anchor for sustainability, and a leader in environmental health and justice. Healthcare Without Harm has regional offices in Asia, Europe, and the United States, a regional team in Latin America, strategic partners in these countries, including India, and an international partnership with UNDP, WHO, and other organizations. One of the strategic partners in India is the Center for Chronic Disease Control. CCDC is a New Delhi-based not-for-profit, and it addresses the growing challenges of chronic diseases through knowledge generation, as well as bridging the gaps between research and effective implementation. CCDC has been a partner of Healthcare Without Harm since 2016, and since then we have been implementing Healthcare Without Harm projects in the country. One of the initiatives of Healthcare Without Harm is the Global Green and Healthy Hospitals Network. This is an international network of hospitals, health systems, and organizations that work towards sustainability in the health sector in the following areas, such as chemical use, waste generation, energy use, water, transportation, food, etc. And currently there are over 1,450 members in 72 countries in the GGHH network. And this network represents the interest of more than 43,000 hospitals and health centers. In India, the GGHH network is known as the Health and Environment Leadership Platform. We currently have about 78 members, which represents over 7,000 institutions and over 100,000 physicians in the country. HELP offers a strong policy advocacy presence. We offer education and training for our member institutions, communication to the public on environmental issues, as well as support to our members in reducing their environmental footprint. Our network engagement channels include our Green Circle newsletter, our Climate Smart Healthcare webinar series, dissemination of case studies in sustainability in the health sector, as well as engagement specific to specific days such as Environment Day, Clean Air Day, etc. I'd now like to invite my team lead, Dr. Purnima Prabhakaran, to give an introduction to the Climate Smart Healthcare webinar series. Over to you, Dr. Purnima.
Thank you, Indu. Greetings, everyone. On behalf of my team at the Center for Chronic Disease Control, it's my pleasure and privilege to welcome you all to the next edition of the seminar series on climate smart healthcare. For most of us, we know that the climate change and the climate crisis is one of the biggest public health challenges of the century, but it also offers the biggest public health opportunity of the century. And in our endeavor to advance the needle on the agenda for climate change and health for India, we have been working with a number of different partners, including Healthcare Without Harm, who Indu just provided an introduction to work with the Indian healthcare sector. And what we have been doing as part of this initiative is running this series on climate smart healthcare in our endeavor to sensitize the Indian healthcare sector, which is a very, very different kind of health sector, very different from, for example, the National Health Service in the UK, which is like one service. This includes private healthcare facilities as well as public healthcare facilities across the Indian states and union territories. So this webinar series seeks to sensitize and build awareness amongst the healthcare professionals on how they play a role in addressing the climate crisis in India. And when we speak of the concept of climate smart healthcare, what we necessarily address is two different pillars. One of them is to do with the climate preparedness or the adaptation response of the health sector. And this deals with the role the health sector has to play in dealing with the increased disease burden that comes with acute climatic events. And that could mean exposure to heat waves, it could mean exposure to deteriorating air quality, to floods, droughts, and the entire gamut of disease, illnesses that come with climate sensitive exposure. Now, that pillar of climate preparedness and the response of the health sector is one whole piece where we work with the health sector to train them in the different aspects of the acute response to disease burden, the surge in disease burden. The other very important pillar that we have been trying to address, and this is fairly a new concept in India, and we have only started working on this for the last 3 years, is on the mitigation of the health sector's footprint. So reducing the climate footprint of the healthcare sector and their emissions across healthcare delivery is the other piece. And this necessarily involves very many different components, right from the siting of the healthcare facility, building its structural resilience, functional resilience, the resource efficiency, where we use optimal, where we have optimal utilization of our resources, which includes the water, the energy, how we manage our waste, our transport, our procurement of medical goods and equipments, as well as an overarching piece on leadership. So we have a number of peer leaders in the country who have been working, not necessarily knowing that this is climate smart healthcare, but have been doing a number of good things in their healthcare services to address the issue of reducing the carbon footprint of their own services. So today we are addressing a very important piece around telemedicine, and we have with us some really distinguished panelists who are going to help us by throwing insights on how telemedicine speaks to the concept of climate smart healthcare. So with that, I'm going to hand over back to my colleague Indumati, who's going to introduce us to the speakers. And I would also like to personally welcome Dr. Colin Cave, Dr. Arun Jose, and Mr. Mohammed Gaut, our speakers for today. Dr. Colin, thank you so much for joining us at a very inconvenient time. I believe for you, you are on the West Coast, but we really appreciate your presence here today. Thank you so much. And thank you, Dr. Arun Jose and Mr. Mohammed Gaut as well. Indu, over to you.
Thanks for the introduction, Dr. Purnima. Our first speaker for today is Dr. Colin Cave. He is the Director of External Affairs, Government Relations and Community Health at Northwest Permanente, which is a US-based healthcare provider. Dr. Colin Cave has been advocating for climate action and for the recognition of the climate crisis as a public health crisis. He has been instrumental in creating the climate action plan for Northwest Permanente. And most recently, he has also published a paper on the greenhouse gas emissions from patient transport and how telemedicine can contribute to reducing these greenhouse gas emissions. So welcome, Dr. Colin Cave, and over to you for your presentation. And I will just share your slides.
Thank you, Indy. Thank you, everybody. It's an honor to be here today. Very much appreciate the invitation and delighted to participate in this esteemed panel. So I think Indu is going to go ahead and pull up my slides. Here we go. Thank you. So to start, I am Colin Cave. I'm a head and neck surgeon, and I've been with Northwest Permanente now for nearly 30 years. In my current role in the past 6 years as a Director of External Affairs, Government Relations, and Community Health. We can go to the next slide. So Northwest Permanente is the medical group to which I belong. Combined with Kaiser Permanente Health Plan and hospital services, we provide fully integrated medical care to over 628,000 patients in Oregon and Southwest Washington, 2 states on the west side of the United States. We have over 1,400 physicians covering all specialties available. We have 2 hospitals that we own and run. We contract out with several other hospitals up and down the Oregon and Washington geography. And we have over 35 medical offices. Next slide. One of the reasons that I'm here today is that Northwest Permanente is the first physician-owned medical group in the world to achieve certified B Corp status. This is us with our score, 134 points when we did our assessment for the B Corp certification. We believe that as a medical group, that environment is absolutely an integral part of health. Clean air, clean water, food, housing, All of these things are integral. We call the social determinants of health as well as the environmental determinants of health. We did publish the first climate action plan among any major medical group in the United States. And this really drove home to us a couple of years ago when I was working in an air quality of over 600, as well as driving home in 109 degrees heat, both of which are unprecedented for Oregon, but we've had our share of fires and bad fires at that, ruining both our health as well as destroying complete neighborhoods throughout the state. Next slide, please. So virtual visits is not healthcare 101, it's more healthcare 202 or 303, if you will. And so with regards to the electronic medical record, about 25 years ago, I was one of the first 150 desks to have the Epicare electronic medical record installed on my desktop. Epicare is the electronic medical record that we use. And back in 2015, so about 7 years ago, we started our first virtual visits. Now, for the purposes of this talk and for the paper that we wrote, virtual visits are real time. So they would be either phone calls or video visits. There are what we refer to as asynchronous options, and these include emailing your physicians back and forth, nurse calls that would then forward on to the physician for advice and then go back to the patients. And there's also newer artificial intelligence programs that we are using, still not quite to the same level as the video and phone call virtual visits. Next slide. This is just a brief history of the virtual visits that we have experienced in the Northwest. Primarily primary care, specialty care, and mental health are what we started in 2015. And this slide should all say up to 2022. I keep forgetting it's 2022 when I write my checks and enter things, but we've been doing this now since 2015. We do have a couple of different types that have started and then stopped for other reasons. Primary care at home, CERTAN, which is basically where we had a physician embedded in the regional nurse telephonic center. And if the nurse thought that we could keep somebody from having to go to the ER or the urgent care, but they weren't able to put in the order, they would bring the physician over who would then intervene. The regional telephonic medical center is still working. That's out of our emergency room. These are emergency room physicians and specially trained internists, and their job is to deal with more acute level phone calls, transferring patients back to our system, and then determining whether a patient should come in or whether we can send a paramedic to them to work with a physician telephonically. Our palliative care clients are all having access to our virtual visits. And then we talked about the artificial intelligence e-visits. We've used BrightMD, which is a third-party vendor, and we'll be switching that over this year to e-visits on Epic. But basically what this boils down to is our patients can log on, enter a series of questions for a given number of conditions. The artificial intelligence then spits out what it believes is the most likely diagnosis. A physician reviews all of the AI output and then gets back in touch with the patient with a treatment plan. This would be one of our asynchronous visits. This increased 45% in use in January with Omicron hitting our state. So we continue to experiment and grow our e-visit profile. Next slide, please. So virtual visits began as a convenience to our members. Obviously, if you're at work and you have to leave work and drive to the doctor's office and wait for a late physician and then go to the lab or go to the pharmacy and then drive back, that can be 4 hours out of your day. By providing virtual visits, we found it was a convenience to our customers, our members, our patients, as well as to the employers that hire these people. And so that's how it started, but it quickly became a safer means of caring for patients during the COVID-19 pandemic. Next slide. And again, being a B Corps and looking at the world through the lens of a B Corps, where environment and the communities we serve are elevated to the same level as the balance sheet, we were hoping that COVID mitigation measures such as telehealth might help with global warming. And so we decided to look at how our virtual visits might reduce our greenhouse gas formation and be at least one benefit of COVID, which didn't seem to have other benefits around. Last year, I co-authored an article in the Journal of Climate Health and Change titled Patient Transport Greenhouse Gas Emissions from Outpatient Care at an Integrated Healthcare System in Northwestern United States, 2015 to 2020. Basically, the title just says, look, we cut back on a lot of people driving back and forth to visits, and how did that impact our environment? Next slide, please. So this slide is one of the two that are important in this talk. If you look along the bottom, you'll see the dates or the years of our collection of data. Along the left side are the total number of visits in hundreds of thousands and millions. The in-person visits are the blue aspect of the bars, and the virtual visits are the green aspects of the bars. And you'll also see that this goes from 2015 through 2021. Our paper ended in 2020. That's with our last full year of data included. But for this slide, we've also added 2021, and I'll talk about that in a second. So from 2015 to 2020 inclusively, the medical group completed 15.6 million outpatient visits on our some 620,000 patients, averaging about 2.6 million visits per year. Although the COVID pandemic reduced visits in 2020, and you can see just a small drop, not nearly what we thought we would expect, just a small drop. Overall, we saw a 15.9% increase in visits over those 6 years. Now, what you'll look and see is that the inpatient visits increased about 1.5% per year through 2019. So our population of patients was growing, and we did have an increase in inpatient visits. That declined by 46% in 2020 due to COVID-19. At the same time, the telehealth visits were growing at a much faster rate. So although the green bars are smaller, you can see that they are growing proportionately faster. And our e-visits, our virtual visits, were growing at 39% per year through 2019. And then in 2020, it jumped by 108% in 1 year, all because of COVID. And in 2021, when things quote unquote normalized a little bit at least, we did see a little bit of increase back to more in-person visits, but nowhere near what we saw before the COVID pandemic. And in talking to the operational leaders currently, in primary care especially, we're not sure if that number is best going to be 50-50, 50% inpatient, 50% virtual, or 60-40 or 40-60, but it's probably going to sort itself out somewhere in that 50-50 range, plus or minus 10%, which again is a significant change from what we had before the pandemic. Next slide, please. This slide is taken straight from the paper. Let me orient you to this just a little bit, because this is the most important slide we have. The years are along the bottom. Again, it goes through 2020. It does not include 2021. The amount of carbon produced by these visits is along the left-hand side. The red bars are the amount of carbon that has been generated from in-person visits, and the green bars going down are the amount of carbon saved from having virtual visits. The blue bar we'll talk about, or the blue line, pardon me, you can see has a gradual downward slope. That's the carbon intensity per outpatient visit, which I'll talk about in a little bit. And so let me go ahead and delve into this a little bit. The greenhouse gas emissions from patient transport, or basically driving back and forth to the offices, is shown in this figure, and it increased from 18,500 tons in 2015 to about 19,500 tons of CO2 equivalent in 2019. This then dropped precipitously to 10,500 tons of carbon in 2020. So about a 9,000 ton drop just for our region. The carbon intensity of outpatient visits dropped from 8 kilograms of CO2 per visit to 4 kilograms of carbon per visit. And so as shown again, that blue line, that carbon intensity was slowly dropping from 2015 to 2019, and then a large drop in 2020 corresponding to COVID. Next slide, please. So let me take a minute and just talk more about this. What is this? This is the number that matters to us. And this is the number that we hope actually catches on around the world, if you will. When two of our co-authors are from Boston area, and they were both from two different hospital systems. And in Boston, each hospital system is required to share its carbon efficiency. And they have used as the denominator the square foot of building. So if you are a system that has one building and your CEO decides that you're going to use that building 7 days a week, 10 hours a day, and you are really going to make the most efficient use of your resources, then ironically, your carbon intensity in that system is much higher and you look worse than a CEO who decides to build 5 hospitals or 5 clinics, stay open 4 days a week, have large open floor plans, and then you're not using those rooms very much, so your carbon intensity per square foot is much less. And intuitively, this makes no sense because we know if we build more buildings, you have more concrete. Concrete releases tons of CO2. You have to heat and light and do all of those scope 2 things in addition to your scope 1 things to keep those additional office buildings open. So we were wanting to look for something that would be more universally applicable. And we came up with an ambulatory visit carbon intensity. And what that boils down to is it's just the greenhouse gas emissions normalized by the number of patient visits annually. So the number of patient visits is now the denominator instead of the square feet. And this also matters because what we found in reducing our in-person visits is that we were able to close 4 clinics. Now, in closing those 4 clinics, then we would be rewarded in our numbers with the reduced scope 2 to keep those clinics operating, less energy used, less lights, etc. And so as you move forward, if you're able to improve the efficiency of your outpatient visits, you get to be able to show that with your reduced ambulatory visit carbon intensity. Next slide, please. And so what started as a purpose for patient convenience, employer convenience, then moved on to actual more safe patient care during COVID. We could keep people out of the hospital so they weren't exposed. We as physicians would not be exposed as much. And then we realized that, wow, this is not just patient convenience. This is not just safety. This is also improving our environment and our world. And as a B Corp, we're very proud of that. Next slide. So thank you for the opportunity to talk. I'll go on mute and I look forward to answering questions at the end after I have a chance to listen to our next 2 speakers. Thank you.
Thank you so much, Dr. Collin, for giving that presentation and introduction for our webinar. And now that we've seen how telemedicine can reduce the footprint of healthcare, we'll now move on to the Indian context and provide 2 case studies of telemedicine that are being implemented in the country. First, we have Dr. Arun P. Jose. He is the head of the Center for Digital Health in Public Health Foundation of India. He is leading the Digi Sahayam initiative in the country, which is an assisted telemedicine service in India. He is also doing capacity building work in the space of cardiovascular disease, strokes, and other areas for physicians in the country. So welcome, Dr. Arun, and over to you for your presentation for the case study of Digi Sahayam in India.
Thank you, Indumati, and I hope everyone can see my screen. So,
yes, we can see it.
I think as Dr. Purnima mentioned at first, I think we would be one of those people who've been practicing telemedicine, not really paying attention to how much of environmental relief it brings in terms of reducing the carbon footprint. And we've seen from Dr. Keir how incredibly it works in reducing carbon footprint and in reducing the environmental hazards that the healthcare industry poses. I'll be presenting a small case study of the Divi Sahayam initiative that we are doing at PHFI. I'll start with this image, just to give you a small background of as to why we started thinking about telemedicine and why we thought it was really important. So these scenes became very common after the start of the COVID pandemic, which saw the tertiary care hospitals overwhelmed with patients. The patients who had already suffered from COVID did not have any place to go to get their post-COVID sequelae examined. And we saw that the weaknesses and the vulnerabilities of the health systems across the world, and especially in India, was exposed because of the COVID pandemic. But there was a certain group of individuals that were particularly affected because of the COVID pandemic. And these were individuals with non-communicable diseases and chronic conditions that required regular follow-ups, evaluations, and care. And these were all interrupted because of the COVID pandemic. And in addition to this, the COVID pandemic harmed or affected the people that required it the most, the people that were marginalized, vulnerable sections of society living in rural, remote locations. And with this in mind, we thought that telemedicine could actually help. It could improve access to primary as well as tertiary level care to all these vulnerable sections of society. It could improve care for COVID-19 itself by reducing progression from mild to severe forms of illness, providing home-based care for mild illness, and also providing care to post-COVID patients. And moreover, we thought that this would be a very good way of ensuring continuity of quality care for chronic and non-communicable diseases that was very much hampered in the midst of the COVID pandemic. In addition to this, telemedicine has a lot of health system benefits. It really helps with task shifting and easing the burden on the overburdened healthcare manpower. So we already had very little manpower in India, which was even more under pressure because of the COVID-19 pandemic. There's digitization of health records, which helps in improving continuity of care and reducing the footfall in tertiary care centers, and also preventing the spread of COVID-19 itself by reducing exposure. And in addition to this, it could reduce indirect healthcare costs. Most of the patients that travel from rural, remote locations spend a large amount of money because of their travel or loss of daily wages. And it could also prevent complications through improved awareness, early detection, timely referral. And most importantly, the reason why they gathered here, which is it promotes climate-friendly healthcare and reduces the carbon footprint of healthcare industry. So what is the current status of the telemedicine industry in India? So to give a better legal framework and formalize the role of telemedicine in healthcare, the TPG, or the Telemedicine Practice Guidelines, were released in the month of March in 2020. And with that, there was a huge jump in the number of telemedicine providers in India. The government itself launched the e-Sanjeevani program in the public sector, and there was a mushrooming of sorts of numerous private entities that entered the telemedicine market. And it's been reported that there's been almost a 3 to 4-fold increase in teleconsultations across India. So the reason why we started telemedicine was to improve health equity. And we were asking ourselves the question, has telemedicine really improved health equity, or is telemedicine increasing the digital divide or increasing the health inequities that are present within the public? So when we did a small survey, we found that the digital divide still exists in India, despite the telemedicine providers increasing in large numbers and the telemedicine consultations also increasing. We found that there was very poor penetration and acceptance of telemedicine in rural areas. And even in the urban areas, the utilization of telemedicine was subpar. When we did a small survey amongst patients and physicians, we found that there were multiple barriers that patients experienced in trying to access telemedicine. So amongst the patients, the challenges in accessing telemedicine was mostly due to literacy, language, or technology level barriers. The digital literacy in India is still very subpar, and most of the patients were not able to utilize a telemedicine platform even if they had one. And to our surprise, even physicians did not enjoy using a telemedicine platform because they did not have access to the clinical history or physical examination findings or laboratory parameters that usually aid physicians in evidence-based decision making. And when we surveyed the digital health technology market, we found that there were multiple innovations that were available, but none of these were on an interoperable platform. And most of these technologies were either not being used at all or being used in isolation. So we decided to conceptualize and create a alternate healthcare delivery model which used telemedicine, but in an assisted format. So what we did was we tried to improve the quality of healthcare through bridge personnel that were trained in providing assisted telemedicine solutions. And we thought of solutions for each of those barriers that we found at first. So with literacy, language, or technology level barriers amongst the patients were bypassed by trained healthcare workers that were responsible for connecting, conveying the findings, and facilitating doctor-patient interactions, and also preventing wasteful visits. So this is another complaint that we got from the physicians. Most of the telemedicine platforms in India ask the patients themselves to choose which specialist or which super specialist they would like to visit. And the nuances in these led to a lot of patients choosing the wrong physician for their particular problem and leading to a wasteful visit. The second barrier amongst the physicians was again taken care of by the trained healthcare worker that would collect the history, perform a good physical examination, carry out lab investigations before initiating teleconsultations, thereby saving time and also improving the quality of care that was possible on a telemedicine platform. And lastly, what we did was we created our own telemedicine platform, which embeds electronic health records, point of care diagnostic devices, inbuilt electronic clinical decision support system, and various state-of-the-art digital health technologies, which help these healthcare workers collect a better history or do a better physical examination and make these telemedicine visits more fruitful. So some of the salient features of our telemedicine platform was that we upscale the skills of our healthcare workers in providing assisted telemedicine. We try to improve access to primary as well as tertiary care through these trained personnel. We try to improve quality of care that can be provided over telemedicine through the use of various point of care diagnostic and electronic clinical decision support systems. We also reduce the need for follow-up visits to large healthcare facilities, which were largely inaccessible due to the COVID pandemic. And we also built in real-time monitoring and feedback mechanisms that assure quality of standards. A little bit about our telemedicine platform, which we call the PHFI Innovations Cortex. So these are some of the digital health technologies that we have embedded within our platform today. The first one is a homegrown technology called as Empower, which is an electronic clinical decision support system, which embeds approximately 2,500 to 3,000 case studies in its backend and helps the physician make an evidence-based decision for their patients. In hypertension and diabetes, it would give the physician support in which drugs to prescribe, what side effects could be seen, or what drugs would possibly interact with each other. So this system was embedded into the telemedicine platform. Apart from that, we also embedded a point of care diagnostic device called as the Swasthya Sahayak, again built by PHFI. This device, the size of a tablet, is capable of doing over 15 investigations. And this was Bluetooth enabled, and all the results were directly conveyed onto the telemedicine platform, thereby removing any chance of human error in entry of these results. And this made laboratory results like blood sugar, urine protein and sugar, and various other investigations available to the doctor so that they could make a better treatment decision. We also paired it with an ECG device. So it's called the CardioScreen, which is an FDA approved and CE certified cloud-based 6 to 12 lead ECG device. And this would enable the nurse or the healthcare worker to take the ECG, and via the cloud, it will be directly transmitted to the telemedicine platform. And this is AI enabled, so it would also give the physician support in reading the ECG. We felt that it's important for the physician to have better control over the teleconsultation. So we paired it with a digital stethoscope, which would enable them to auscultate the patient and also record period auscultations in multiple visits so that they can compare it with the previous visit and actually see whether the patient has been improving. And we also paired it with a remotely controlled high definition camera. So the physician sitting at the remote center at the tertiary care hospital could actually point and zoom and move the camera 360 degrees to get better control over the consultation. We also designed various models of service therapy. So the first thing that we did was we built designated telemedicine centers. So these were physical structures, small rooms that were probably around 150 to 200 square feet. And this would be functioning with the help of a telemedicine nurse and a lab technician, and also supervised by a project quality assurance officer. So what we did was we made general physician specialists as well as super specialist consultations available over here. And any existing private as well as public health facilities could be easily upgraded to perform this assisted telemedicine function. So how the clinic workflow is that the patient visits the clinic, the trained nurse takes the history and examines the patient before consulting the doctor. So they would also conduct lab investigations that are necessary and then initiate a virtual consultation with a doctor. And immediately they would also refer the patient to a super specialist, thereby decreasing the amount of time that the patient needs to spend at the health facility, reducing the exposure to various pathogens and infections, and also reducing the need to let go of an entire day's wages. And after this, the patient would go for post-consult counseling by the trained nurse. We also surveyed, or we also studied the government sector, and we found that all the government health facilities could be easily upgraded to perform these assisted telemedicine services by simple training of some of the staff that were already there. And we have tried this out. When we found that some of the patients were still unable to come to our clinics, we also found that all of our equipment, all the equipment that I had shown you earlier, was all battery powered. They work with a simple 4G internet connection, and they all fit into a very compact backpack. On the left-hand side, you see one of our healthcare workers who has all those equipment in those two small backpacks, and they would actually go to the household of the bedridden or the elderly individual and initiate a teleconsultation from there, thereby making it more accessible. And we also conceptualized models where in rural areas or hard to reach areas, we would actually have a mobile unit that would go to these rural areas and provide assisted telemedicine for the entire village in one go. The potential impact that we see is that we think that this can bridge the gap that the community faces with technology and digital healthcare through the trained personnel, and making telemedicine and digital health more accessible and usable for the population. We think that this can improve continuity of care and longitudinal health data through the use of inbuilt electronic health records. It can create an innovative model for health service delivery that is sustainable, accessible, and affordable. We can reduce indirect healthcare costs and travel and loss of daily wages. Can provide valuable data that could inform the development of suitable healthcare models, and also prevent complications through improved awareness, early detection, treatment, and timely referral. A lot of the health technology issues that the systems face today has been taken care of by this model. That includes cost, quality control, interoperability, scalability, privacy, and we've taken a lot of care to focus on user experience and the contextual needs of that particular place. The DigiTime project was also featured as a case study in the Climate Smart Healthcare for Healthier Populations in the COP26 a conference that took place at Glasgow, and we were the first case study that was represented in this Pocket for Future. Some of our collaborative projects, we started off with a project that is supported through the CSR grant of a company called Star Health and Allied Insurance, with which we established 3 clinics in the state of Tamil Nadu. One was in the rural region of Pasubanthanai in Thoothukudi district, and 2 in the urban slum locations of Chennai city. These are some glimpses of our clinics at these locations. And on the bottom left, you can see how the nurse actually stays beside the patient throughout the consultation and connects and conveys and facilitates this doctor-patient interaction. We've completed almost 10,000 consultations over the last 1 year, and we've almost touched the lives of around 20,000 people through health education and spreading awareness. Seeing this model, we were also adopted by the World Health Organization, who supported us to set up a regional demonstration project. In this project, we are working with the government of Karnataka, where 2 primary health centers in the district of Chikbalapur of Karnataka are being upgraded to provide the DigiSahayam assisted telemedicine. And this is being evaluated for adoption and scale up in the Southeast Asian region. With this, I will stop and I'll be taking questions at the end.
Thank you so much, Dr. Arun, for giving the presentation. We could see how telemedicine was set up, DG Sahayam was set up, and the process, you explained the process of how it was set up in the country, which will be helpful for others who wish to do similar initiatives in the country. Now we will move on to our next speaker, who is Mr. Mohammad Gaut. Mr. Mohammad Gaut is the senior faculty of Lions Arvind Institute of Community Ophthalmology, which works on best practice knowledge sharing and capacity building in the field of eye care. He also oversees the vision centers of Arvind Eye Care Hospital, which are assisted telemedicine services provided in peri-urban areas. I also had the honor of visiting one of the vision centers a few months back and seeing the amazing work that they do. So I'm pleased to invite Mr. Mohammad Gaut to share more on the vision centers that Arvind Eye Care has. Welcome.
Indumati, could you see my screen?
Yes, we can see your screen. It's on presenter mode, so we can. Can you see? Yeah.
Fine.
Yes, it's fine now.
So thank you for the opportunity. So let me going to share the story of Arvind Eye Care System, how we started enabling vision centers. So one of the important thing about Arvind Eye Care System is we started as an organization in 1976 as a 11-bedded hospital. And community outreach is part of the entire working pattern of Arvind Eye Care System since it was started by Dr. G. Venkateswamy. So we put a lot of initiatives to reach the communities since 1960s when he was working in a government hospital, and it was continuing even now. The point here is that we did a study basically to ensure that what is the proportion of people that are actually attending eye camps from the base of need. So what we found out is very interesting thing. So one side of the coin, if you look at that, every year Arvind do close to 2,500 eye camps, and 500,000 people will be screened in the communities, and 100,000 cataract surgeries were done. Another 100,000 people get eyeglasses, and another 25,000 people get specialty treatment through that eye care. But the other side is a little different. That from the efficiency point of view, we are actually good. But then what is actually happening in the community, if you look at the denominator, it's close to 7 to 10% of the people were actually accessing eye care. So rest of them were not actually coming to the eye camps because of the social and other eye conditions. People have priority. No, there is but no single day that everybody will be available in the community. So the other important things were like rare eye conditions were not addressed as it is intensively towards cataract, refractive errors. No. And finally, the key point is that services were not continuously available. So we were in the hindsight trying to figure out what can be done to the community. Something need to be actually available to the community permanently. And then we should not be compromising on the quality of eye examination, and the services needs to be a bit more comprehensive in the community. And working in all these like 4 decades, Arvind also have an experience of the closing the care loop from diagnosing the eye condition to ensure that the patient eye conditions are resolved for which they came to us. No, so that's what actually taken us in terms of a good performance and also reaching more people. And third important component is like developing a denominator-based eye care facility, which means like in a community, say 100,000 people are there. Like today, 25 to 30% of the people need some form of eye care. No, how can we reach those entire community by having a model permanently available to them? And also, by when we need to do so, we need to remotely manage and control the key aspects of management like human resources, supply chain, finance, all those things. So that's how the primary eye care facility came into existence somewhere in 2004. And from the day one, we started functioning on all days. We designed the model in such a way It will be staffed by, it is from the day one, it is staffed by the allied ophthalmic personnel or vision technician or optometrist or ophthalmic assistants, whoever said. So we have a intensive training program for them, skill certified before we post them. And there needs to be a hospital linkage on day-to-day basis. There is a base hospital for eye care, and then on day-to-day basis, they need to do a case basis. They have to do a teleconsultation, and all these were done through electronic medical records, so that we can easily retrieve the records easily. And it was done since, I mean, 2004-5 we started doing all these things. And those days it was not the broadband was available like now. So we established our own Wi-Fi towers with the help of students from California, Berkeley. They want to do education on telemedicine. So we use that opportunity, and then we established those connections. And the first 2023 vision centers were actually functioned through this network. So if you look at today, so these vision centers actually were designed for 50 to 75,000 population. And these are all permanent facilities functioning in 400 to 500 square feet. And then provide comprehensive eye care at their level. Provide first aid for emergencies, because if you look at the rural India, elsewhere you go, a lot of agrarian economy and agricultural, I mean, farmers are there. So the first thing that used to happen is that people used to get a lot of foreign bodies and then infections, infiltrations. No, with that, people used to come to a primary eye care center, which really need to be dealt in a better way. So they also this also bring in a lot of trust and faith on us. And then this is a mandate thing that every patient who visits vision center have to undergo a teleconsultation, end up the entire findings and other things recorded in the EMR. So, for example, today at this point, Aravind actually do like close to 2,300 to 2,400 teleconsultations every day. And EMR, I mean, of course, over a period of time, like the previous speakers mentioned about it, it really it drastically reduced the usage of paper, and in fact, it have a greater influence on the economy, and then having a bigger impact on going green. And access to drugs and spectacles that are delivered to the patients, because that's where most of the services need to be delivered. And a good follow-up care for those patients who need glaucoma services, diabetic retinopathy patients. Today, when we started, we don't have a fundus camera or something like that, but today we have state-of-the-art facility in the primary eye care itself. Some of them having artificial intelligence in place to diagnose diabetic retinopathy at the earliest stage, all those things. So in terms of service delivery, optical dispensing is done at the vision center with the varieties to the patient's choice, and also reflecting on the local economy. We provide support maintenance for those people who bring the repaired eyeglasses, and the medications were provided locally. Wherever it is not possible, we try to collaborate with the local medical shops so that we can prescribe, e-prescription can be sent to them, and then our staff will explain the usage. So one of the important things that we found out is the staff attitude, skill, and understanding the purpose of primary eye care centers, vision centers, helps in clear explanation and increase the acceptance among the patients. So keeping it affordable and sensitive to the local community, have an inclusive pricing in place today. Like we charge around ₹20 or $1/4 of a dollar as a consulting fee, which is good for a comprehensive eye examination, which includes applanation tonometry to measure the intraocular pressure in the eye, and then slit lamp examination, and fundus imaging for a 40+ aged person. So all those things were included in that one package. And then it is also good for 2 additional visits, because we found in the rural areas, there should not be any entry barrier. At the same time, people also feel that they are giving something to get the care. So these 2 things were widely considered when we fixed the charges. And then we don't find any barrier when the people are paying like $100 or $200 for an eyeglass and then getting it done. So So the entry barrier should not be there. So we keep it more minimal charges, the consulting fees, and keeping the entire comprehensive eye examination available for everyone. So with all this design, we could serve locally at least 85 to 90, 85 to 89% of the patients treated at vision centers. Only those who need cataract surgeries or specialty advanced treatment for diabetic retinopathy or retinal issues or some complicated eye conditions, no, they will be referred to the base hospital with the clear escorting in place. So the advantage of telemedicine from the different perspective is for a rural patient, it consults with an ophthalmologist, assures quality in addition to the technician's diagnosis, reduces travel costs and save their time. You will be seeing in detail what impact it created in terms of saving the cost and also in terms of impacted the environment. Early detection of chronic eye conditions like glaucoma, diabetic retinopathy. When we speak about eye care, in most cases we speak about refractive error and cataract, but these are all silent thefts of eyesight. So glaucoma is kind of a close to 2% of the 40 plus population prone to have glaucoma, and then not even 50% of them were diagnosed with the condition. So and then unlike cataract or refractive error, glaucoma needs a continuous medications and follow-up. So it's very important to diagnose it as at the earliest stage. And then, as I told you earlier, only 12% of them need to go to the base hospital. For the vision center staff, if you look at as we do teleconsultation and telemedicine with an ophthalmologist, so just imagine like 5,000 patients were seen in a primary eye care center. Every case they present or every patient the staff present to the ophthalmologist and getting a confirmation that they are doing right job. No, so it's a kind of an acknowledgement and a continuous improvement for their own work. And the staff also get recognized by the local community. This is very much appreciated by everyone who is listening to this conversation. And for hospitals, the extension of service area for small hospitals is definitely extension of service area. It makes presence it actually ensures their presence in the villages, and they can focus on surgeries and specialty procedures instead of focusing on minor eye conditions, and helps in decreasing the burden of needless blindness in their particular area. So, and finally, like for the environment, if you look at reduced carbon footprints as patients travel less for eye care. So this is one interesting thing, like Dr. Arun P. Jose, I also want to mention this, but in a different way, as we were actually having close to 75 vision centers when the lockdown was announced. And Arvind have around 7 tertiary eye hospitals which see close to 1,000 patients to 3,000 patients per day. And we also have 13 secondary eye hospitals which sees close to 200 to 500 patients per day. So once the first unlocking began, it was really interesting for us to note down that vision centers could pick up within 1 week 66 to 70% of their original volume, whereas the secondary, tertiary, and larger tertiary hospitals of us could reach the potential of close to 25, 11, no, something like that. So at least in future, if some crisis like this exist, no, like Dr. Arun Jose told, or it is mentioned by Dr. Colin Cave, no, and then from our own perspective also, I mean, what the evidence that we have at this point, the primary eye care centers or primary healthcare facilities with the telemedicine will be able to pick up faster than anything else. So it is better to strengthen that part. And currently, Armin have 95 primary eye care centers, telemedicine-enabled primary eye care centers, the entire Tamil Nadu, and one center in Pondicherry area. So this is the volume that we have seen in the year January to December 2021. Close to 700,000 patient visits were handled, of which 60% is unique patients, and 40% is review patients. Close to 40% is review patients. And then 89,000 eyeglasses were delivered to the community at an acceptance rate of 80%, and 26,000 cataract surgeries were done on those patients, and 31,000 patients visited the hospital for specialty care. Very interestingly, when you are being local, and then if you offer the service at their level, So people are willing to accept your services, and they also pay for the services. So this is one interesting slide which is going to reflect on the context of the workshop that is organized. This is about a Pondicherry hospital, Aravind Pondicherry Hospital, which is actually having 14 vision centers, and they introduce a concept of same-day surgery, which means the patient advised from the vision center, they need to travel somewhere between 40 kilometers to 90 kilometers. For example, the first one which you are seeing, Penadam, which is like 98 kilometers from the base hospital. And what they have done is that the entire examination, pre-examination should be done in the vision center itself, including the physician opinion with the collaboration from the physician. And the patients were guided to go to the hospital on the early morning of 7:30 a.m. Once they register, the patients will be escorted for the further procedures, and the patient get the surgery done at 10 o'clock. They go back to the home at 1 o'clock. The reviews will be given in the primary eye care centers itself, which saves a lot of money for the patients, and especially cataract patients. If you look at, they were all like somewhere between 65 to 70 years old, or 70 plus years old. So naturally, the traveling, all those things make them a tedious thing. So in addition to this, they save a lot of money. Number one, number two, the discomfort, and then the other thing is that a lot of carbon footprints in terms of travel is completely safe. So we actually want to escalate this, across Aravind. So this is one of the interesting point to note down. And this is about the savings that we have due to the vision centers. For example, I calculated like 50 kilometers as an average for a patient to travel from the base hospital from a vision center locality. So at least he takes like 50 rupees, and then food and other expenditure 120 rupees, and loss of wages would be around 300 rupees. So he also need to take an attendance. So together it costs like 940 rupees approximately. And if you visit a vision center to get the care, somewhere around 300 and it is around 355 rupees only he used to spend. So approximately the amount that he saves, there's a huge amount of money is saved towards every patient, and towards the number of patients, say 6,98,000 patients. If you look at like 33,513 tons of carbon emissions were prevented in terms of transport and other things. So that's another interesting thing to note because of the vision centers that are working in the communities. And by doing all these things, it also supports the universal coverage for eye care. What I share here is like a 75 centers data till 2019 March. So if you look at the first thing is the amount of eye conditions, and the second one is the estimated eye care need. This is based on several studies that came out that provides the prevalence, and then what is served over a period of time, and then the coverage. So with a good primary eye care facility available in a rural area, I think the universal health coverage for eye care is fully possible. In addition to this, LICO also supports scaling these vision centers across India and different other countries like Bangladesh, Nepal, Guatemala, and then many African countries. We are consulting with them. And this is the work that we have done outside the Aravind. So we have fixed our own goal of reaching with the primary eye care for 1 billion population globally. And in India, we worked with the 12 states across, which includes the government of Tamil Nadu, Chhattisgarh, Tripura, and many other government. We shared our software for working, and recently we are working with Arunachal Pradesh. And similarly, the entire government of entire Bangladesh, the government is going with the Pan Bangladesh setting up of vision centers, Pan Bangladesh, like 400 vision centers to cover the entire Bangladesh population of 17 crores approx. So we were closely working with them, hand-holded their staff and then trained their staff. No, all those things were done in place. And we also collaborated with the Millennium Alliance program, where we work with 4 hospitals, and we are working with them to establish their own primary eye care centers and then making them sustainable over a period of a year or so. And with the capacity building program, we are working with 24 hospitals across India to leverage this particular model. So some of the photographs that we handhold the staff at Bangladesh. So to conclude, point number 1, primary eye care with the telemedicine, like the previous speakers told, it's actually going to be a game changer in terms of reaching people with good quality services, and in terms of debottlenecking the apex centers, the tertiary centers and secondary centers, so that they can focus more on their own the key surgeries and then specialty services. And number 3, definitely going to play a major role in terms of making the environment green by reducing carbon footprints and also saving a lot of money to the rural economy. Thank you very much.
Thank you so much, Mr. Mohammed, for that presentation and explaining to us how the vision centers are increasing access to eye care, as well as reducing the impact on the environment by reducing patient transport, as well as using low energy intensive buildings. Now we are opening up for questions. So if anybody has any questions, please feel free to ask or put into the Q&A box as well.
So Indu, maybe I can ask a question.
Sure.
Wait. So I think my question, first of all, congratulations and thank you to all the panelists. I think this is very kind of presentations and overview of the initiatives that you have at your centers and hospitals. So Dr. Colin K, my question to you is, how easy was this to kind of map your footprint in terms of the emissions across your facilities? I mean, you have some really excellent data. So we are looking to start handholding facilities in India. Of course, Arvind Eye Care has mapped and has the measurement of their carbon footprint. But if we were to do this in India, how easy was this to get to data from healthcare facilities?
So I think the enemy of good is perfect. And I think that was one of those things that we had to sort of sort through for us. For marketing purposes is how we started this many years ago, and we started looking at round trip from the patient's home to their assigned primary care office. What we didn't have was sometimes the specialists are fewer and a little farther drive, so we had to make some estimates, and I think that was one of the potential downsides of our research. But overall, as long as we were consistent, we probably underestimated rather than overestimated our savings. And so for us, I think it's just important to find a number that works. And for us, we were able to do a computer analysis of, we had the addresses of our patients, we had the addresses of their assigned primary care clinic. We determined the average round trip. And then we looked at the average carbon output of an average car in America and the average miles per gallon or kilometers per miles per kilometer, if you will. And so we did a lot of that, looking at averages. We did our best to determine how people transport. Oregon, the state I live in, does have every 10 years it comes out with statistics on how people get around. The great majority are still by cars here in Oregon, over 93%. So I think it's good to just come up with something that is reproducible, that's based on some good logic, and then you can improve that as you move forward. As I said, we had 4 clinics that we were able to close as we increased virtual visits. but it's not just so easy as figuring out what the carbon output of those are, because we still have leases on those buildings that go forward a couple of years, et cetera, et cetera. So at what point do we get to funnel those savings into our decreased carbon intensity? Smarter people than I, typically mathematicians and statisticians, are going to be able to step in and help with that. But at least we have a starting point, and looking at a common language and determining, I think, what, so that we're all apples to apples, what do we want that denominator to be? And I think the main point of our paper was, instead of having square footage or some other efficiency measure that can be gamed by systems that have more money, it's basically the carbon intensity per outpatient visit. We all have outpatients we have to see, and that was the denominator that we were looking for.
Yeah, fantastic. I mean, I think there's lots to learn from the work that you have done there. So maybe a question to Dr. Arun Jose. So Dr. Arun, I think your initiative, Digi Sahayam, was, not just talking about reducing the carbon footprint, but also in terms of the assisted telemedicine, we're addressing also the equity and access issues. And I think pretty much the same for Arvind's Eye Care Center as well. So I think it's important, and my team has also been thinking on the lines of how we can map the footprint for you, your Digi Sahayam initiative. It will be useful going forward, not just as an exemplar, but also to kind of scale it up going forwards within the narrative of climate smart healthcare. So any thoughts around?
Absolutely, ma'am. I think that's really important for us to do at this stage. I think we initially started off with, the health equity concept in mind, and, the universal health coverage concept in mind, and we felt that the first step that needs to be taken was to make telemedicine more accessible first, and then after that, yes, the climate friendly, it is very climate friendly. There's a lot of advantages environmentally with the use of telemedicine, and I think improving health equity and the effects of the good effects of telemedicine on the environment are actually linked, because the people who travel the furthest are the people that actually create all that carbon footprint. So it's the rural people that require more access to telemedicine, because those are the people that actually travel I think I saw on one of the slides, it was approximately 50 kilometers, Mr. Gauss had presented, 50 kilometers for each visit to the hospital. So that's a very large distance, and we can actually increase the benefits of telemedicine in terms of environmental benefits. We can increase it by actually improving health equity, and I think there's a direct linkage between these two concepts.
Thank you. And Mr. Gaut, to you, I think congratulations again on your initiatives with the vision centers. I mean, we knew very well that it was very widely spread across Tamil Nadu, but you mentioned now in your presentation about Chhattisgarh and other states as well. There has been some scaling up across India and Bangladesh, you mentioned. So that's a great initiative around capacity building over there. So how are you looking at, integrating this within the government's program now, talking of digital health mission and Niti Aayog's recent?
So I think we pitched in little earlier, madam, like somewhere around 2013-14, we pitched in this similar idea in Jharkhand, basically, and there was a very good, I forgot the IAS officer's name. He was that time anchoring the entire program with the National Rural Health Mission. So from there we pitched in, and that's where the Chhattisgarh government came in, and then they want to make it pan Chhattisgarh basically, and somewhere they stopped with we trained the entire ophthalmic technicians in Arvind, and then we started like 12, and it is all functioning now efficiently. So I think, and then Arunachal Pradesh is very interesting, such a scattered area, and then people, lot of people need actually eye care over there, especially they have to travel across. We work with a couple of hospitals, and now the state program officer for blindness control program, he came down and then he was asking for some support. So something similar to that in Tamil Nadu, we did it for like 32 locations with the Tamil Nadu government. I think the moment is now picking up, especially post-COVID. I think It's like Dr. Arun Jose was mentioning, it's actually picking up across. So even within this pandemic, Bangladesh could open, especially from their government initiative, they could open like 50 vision centers within the last 1 year during the COVID pandemic. So I think this is the way to go, not only for the primary eye care centers, but I mean eye care, but also for the other conditions which can be treated at the rural level. And very interestingly, that when we educate the rural community about the facility, for example, some of our vision centers were in extremely rural areas, coastal areas, like that, where people were actually understanding it better. For example, we felt that in the initial days, okay, how a village person could appreciate a doctor speaking through the screen, but then they appreciate much better, and they really they go back and then bring in patients, and then we have to introduce and then communicate to them over regularly that you are talking to a doctor sitting in Theni Eye Hospital, or you are talking to a doctor in Madurai. So those initiatives, if we could make, and it's really fantastic over a period of time. So I think very interestingly, some of our base hospitals, our vision centers put together have seen more numbers than our base hospitals during the COVID. That was really an impressive thing for us. In fact, it made us to actually, because the entire eye camps were stopped over the last 1 year. Just imagine so much of volume is stopped completely, and the vision center could actually balance that.
Yeah, I mean, I think I shouldn't be putting it that way, but in a sense, I think the positive fallout of COVID has been a fillip to telemedicine, and I think the positive fallout for the environmental, space, I think by reducing the footprint of the healthcare services, I think it's all come together. Not in a planned way, but it has shown us the way forwards. I think both in terms of providing access to healthcare, but also reducing the carbon footprint. And we saw from Dr. Colin Cave's presentation as well, I particularly noticed that even palliative care, I mean, access to telemedicine for palliative care. So there's the whole gamut of healthcare services that can be provided through telemedicine. So I think it's a great way for us to learn from all of you who are kind of front runners now, helping us guide the way for digital medicine, I guess. So thank you, Dr. Colin Cave. I think it was a great learning to listen to you and the way you have gone about doing this with Kaiser Permanente Network. And thanks, Dr. Arun Jose and Mr. Mohammed Gaut. I'll hand over back to my colleague, Indu, to help close us in case there are no more questions over here.
Yeah, are there any other questions from anybody?
I see your hand.
Abhijit, yeah.
So there's a question from Suherman Suryana that could you also give someone example on this, please? I don't know about what he's asking.
I think it was related to his earlier, which Dr. Colin, I think, answered online. And I think he might have left. He's from Indonesia, is part of our partner network from Healthcare Without Harm in Indonesia. It's later in the night for him now. I think he may have dropped off now. Yeah, Abhijit.
Yeah, so my question is sorry, yeah.
Yes. Go ahead.
Okay, my question is to Dr. Arun actually, regarding the disparity of availability of the telemedicines or the connections that people have between the two communities, the lower communities and the people who have easy access to that. Right from the beginning of COVID actually, have you seen any substantial changes in their attitude or in their kind of behavioral pattern over the time, or it remains the same, or over the time as COVID would kind of decrease, then again this practice of tele-access would be again not much in use. So what is your assessment on that, sir?
Thank you, Abhijit, for that question. And I think, so the reports mention how the number of telemedicine consultations have increased by threefold. And it's also been observed by some telemedicine providers and by the Telemedicine Society of India. They've seen how the number of teleconsultations have increased by over 500% amongst the elderly population, or even the middle age, above the age of 50. But it's it's very difficult to sort of interpret anything from those numbers, because the original value or the number of teleconsultations that used to happen before the COVID pandemic was very, very small. Now, coming to whether we would go back to conventional healthcare and abandon telemedicine once the COVID pandemic settles down, I think telemedicine is here to stay. I think telemedicine definitely has a lot of convenience added to conventional healthcare as compared to conventional healthcare. And once people get used to it, it is going to become more popular. The only danger is, when any system replaces, when it complements the conventional healthcare, it's good, but when it replaces it completely, that's when it becomes a problem. And that's why it's important to address digital health equity issues and digital literacy issues, before it replaces. And I always give the example of money in the sense in India. We used to use cash maybe 5 or 6 years ago, but now people mostly use their cards or UPI, and it's almost cash has become almost redundant. So, and that's similar to what's going to happen in digital health. Digital health is going to sort of replace a lot of components of conventional healthcare, and we need to be prepared for that.
Oh, thank you so much to everyone. Yeah, thank you.
Thank you.
If there are no more questions, we'll close now because we're already over time a bit. So yeah, thank you everyone for joining the webinar, and also for the speakers for your wonderful presentations. And hopefully now we see telemedicine picking up more in India as well as all over the world. So yeah, have a good day and good night for everyone. Yeah, thank you.
Thank you.
Thank you for joining us.
Thank you. Thank you, everyone.
Thank you.